Just almost the picture. Change the outcome.
Welcome back, everybody. I say everybody, welcome back, those that are back. Hope you all enjoyed your lunch. Mine at least was good quality, so I hope everyone else had good food. Good. Are we the curry was really good, wasn't it? Yeah, very nice. Are we recording? Excellent. Okay, good. Not karaoke. Like my son, he thinks if he's going to get something as well, he loses at 25 to 2.
I've learned it's like my husband, I've got to tell him now, half an hour earlier. So just I do it. My son will go, I'll get to 25 minutes, I'll take 25 minutes.
Right.
I make good time like this.
I know, I'm giving it. Okay, just a couple of minutes to let everyone get in and settle down. I think there are going to be a few people still arriving as we start, but that's okay. Okay, so into the afternoon session, and as per the morning, you know, the purpose of the day, the purpose of the meeting, celebrate success, look about how we can share best practice and see what we can do collectively to improve the situation for patients across Wales as part of the network. And I'm delighted with the first talk, and the first speaker is Nicola Reeve. One of the things we've spoken about at lots of these meetings previously is how you might test a network of users. So people who inject together, for example. We've spoken a lot about how well often we just treat the individual, but how could we look into clusters and things like that? And Nicola's got some important and interesting information around that. So over to you, Nicola.
So from beautiful sunny West Wales, and Brendan phoned me a couple of weeks ago and the signal was poor and I was just being polite and I said okay, but then realised he was asking me to speak. So this is about a cluster we had in Llanelli specifically, which happened sort of the end of November last year, and it's still ongoing. So the date is correct from when I did it, but I didn't get a maths GCSE, so don't pick me up if things don't match up perfectly. I can explain after why. There's rationales behind it. So basically, we had I had a patient that come in for his surveillance scan, known alcohol-related liver disease with cirrhosis. Came in with a support worker, had his ultrasound scan. That was just showing what we knew. I've dealt with him over the years, injected drugs many years ago, hadn't been involved with it, did the occasional amphetamine, which he bombed. But preference over recent years had been alcohol and street diazepam. So he'd come in, bit too much street diazepam, and that would bring him in, usually by the police. So that was his preference. So the support worker brought him in, and she sort of went, tell Nicola what's been going on. So he went, I've been injecting, I've been using a bit of crack cocaine. So I went, right, okay, let's do your BBV test. So venous sample showed him to be HEPC PCR positive, went to catch up with him then to give him the result and spoke to him about contact tracing. And I said, look, it's my role to contact trace. I won't say the information's come from you. He was reluctant because by nature, they don't want to be seen as a grass. But gave all the information to a support worker, which I was really pleased with. So his floating support worker from the Wallich was all the information passed on. So she got in touch with me via email with 38 names. And I was like, oh, my heart sunk. Some I knew. So we ended up with 17 positives in total, but I knew some of the cases. Some of the names I knew, if that made sense. And a nice little summary at the bottom. She goes, I've linked in these 4 other names, Nicola, because they're not directly linked with so-and-so, but I know they link in with these other people. So it sort of created that sort of wave from that initial case. So the immediate action was to get in touch with public health. I had a cluster probably about 12 years ago when it was the methadone, and I learned then that I should have contacted public health sooner. So I did it at the start. That was my first job. So contacted public health, contacted the CDAT lead, and I said, right, I've got a list of names. Can we just work through to find out who's with who? So we sort of filtered people out. Obviously, a lot of them, there were certain people I knew. There were cases that I'd already known. Some I treated, but unfortunately, they've never come back for SVR. So I've sort of assumed they're still positive, if that makes sense, because I can't assume anything else. We had 5 reinfection cases, and they were definite reinfections. They'd SVR'd, and some of them meticulously coming to me every 6 months for a test or in and out of prison. So I think the proof is, linking in with people is what we need. We've got to network. We've got to gather as much information as we can. So we had a meeting with public health. I'm going to thank Keith. Keith is sitting there. Keith did me a little graph. As you can tell, I'm no good with presentations. It is what it is. But Keith did me this little sort of flow chart to show that the cases we've had so far are all genotype 1A, which is not a surprise, but similar names coming up all the time. One case had come into hospital, we were linking in with Eastwood Park, everyone was sort of coming together to sort of get as much information as we could. So got involved with CDAT. Hang on, is it not moving down for me? I'll try it that way. So the urgent meeting we got together, and I sort of did an Excel spreadsheet of when they were last tested, when they were negative, where are they now, and it's constantly been updated. We meet 2 weeks, Keith and a couple of the other teams from Public Health and Health Protection, we catch up to go through who is there, what's going on. I have treated quite a few as they're coming through. I'm treating them, retreating them. Some have been homeless. Some have just engaged with the service. We're jumping in as quickly as we can to get people through. There was one person mentioned in the group as a name that I had to do a resistance test on last year, and I linked in with Brendan and Reese, and it was decided not to sort of treat him at that time because he was chaotic. He probably wouldn't have complied with treatment. He's come in now to his last 3 weeks of Vosifai because he's ended up in the dry house and he's doing really, really well. So it's constant networking, and I think that's what's the important thing from here. Networking, you can't do it on your own. You know, we're small teams. It's about getting as many people involved and people that these individuals trust. That's key. And I think, you know, not enough is mentioned about the sort of homeless and the Wallich and all these places. The work they do is amazing. They will bring them to the clinic. They will get you to them. They'll sort of do a lot of work with them. So it's brilliant. So DDAS and CDAT, I asked them to sort of increase the testing. That's ongoing. But it is ongoing because it's about testing as many as we can. There was one lady that had a dry blood spot with DDAS, came back as a negative PCR on the dry blood spot. I tested and it's come back as positive and she's on treatment. That's just something to be mindful of, because I thought I'll do this sort of test. Linking in with James and Gary, they must be sick of emails from me because with Swansea Prison, because Llanelli, that's our remand prison, they were in, out, and there was a couple early release. There was some, the brilliant case, I don't know where Gary is now, I'm looking for Gary, right at the back, man after my own heart. There was one person that came in as an acute hepatitis C. So he had been in a few weeks before, normal liver test, everything was fine. Warrant out for his arrest, came in the back of the police. Now, my office is based in minor injuries in Llanelli, so the nurses came to get me. The police have got somebody in the back of the van that's yellow. Do you know him? Because, of course, I know everyone that goes yellow. So off I went, and I went, oh, he's on the list. Yes, it's so-and-so, he's on the list. So managed to persuade him to come in and get tested. He was a girlfriend of one of the people on the list who's a reinfection, so an acute hepatitis C. Luckily, Dr. Reese was on call, so everything was in place. He absconded and left the hospital, but we know he was an acute hepatitis C. Didn't see him for about 2 weeks. Then the police picked him up, arrested him. He went to court on the Tuesday, custody on the Tuesday. I'd emailed James and Gary, and he went on to treatment on the Wednesday, Gary. So that was amazing, but that just shows the power of communicating, and that's what's important, is just as much communication as possible. We've also linked, like I say, we linked in a lot with Eastwood Park as well. We were aiming to sort of utilise the outreach vehicle that James uses in Swansea, but that hasn't come at the moment, but that's sort of hopefully still on the case. I spread the news with the doctors within Prince Philip, and anyone that was coming in as a risk, they were tested. And I've actually picked up a couple of cases because they've just tested naturally from the information they were given. Also, links with the health protection team has been amazing. So the health protection nurses then, just by the impact of the work, started to come out to my drug service clinic and do vaccinations with me. So if they came in, they were having a booster or they were going on a course, whatever it was. And we're, you know, talking down the line of providing other vaccinations as well. I think, Keith, we highlighted in one meeting, MMR uptake is low. So can we look at the health protection nurses doing these? So while you've got that audience, and can I just say, not one person refused to have a vaccination, not one of them. You know, so they basically went, do you want a vaccination? I think I've had them in prison. Should we give you a booster or should we start to go, yeah, come on then. You know, the arm is where do you want it? Which was, one of them was quite ready to take his trousers down, but we did explain it wasn't there. But it is still a work in progress. It's still ongoing. We're still meeting every couple of weeks. The list changes. One, unfortunately, the youngest one we had is 22, I think, James, was he? That lad in prison, 22. he unfortunately was early released, went without his meds. We thought he was in a baths house in Swansea. James and I were linking in. Bless James, he was trying to chase everywhere. I was linking with probation in Llanelli. We couldn't find him. Then he got rearrested, but no time to do his test in that rearrest. I saw him last week, tested him, and he's come back as positive. So it's going to go down, I assume, a resistance test now, Brendan, isn't it? Down that line, he did a month of Maverit. So yes, it's ongoing, and I've had, out of everyone I've treated from this sort of group so far, I've had one. I know that one, the early release, I think if that hadn't happened, he would have carried on, and sort of he identified that he went without his meds as well, you know. But there was one guy that dropped out completely after a month, and he's gone. We can't find him as well. But everyone else has got to the end. I got end of treatment, SVR, so it's just the following up. So it's going well. Brendan's staring at me now. So I better stop.
Josie?
When you had that kind of cohort of 38, were you able to snowball contact trace a bunch of those other individuals?
Can I tell you, there was a lot of the individuals that were related, if that makes
Okay.
sense. So I know this group, the names. I know some names, we had nicknames, and we had two in particular, we still have not found out who they are from the nickname. So we're still sort of guessing. We've had a nickname given initially, then finding out, actually probation said, actually this is so-and-so, he's in Swansea. Gary did the test and has come back as negative. But yeah, can I tell you, Josie, it is actually, if I was channeling it down, it's Llanelli, but it's an area of Llanelli. I can channel it down that tightly. And some have sort of relocated to a different area. So I could literally pitch myself in two specific sites in Llanelli.
Reece, did you have a question?
Yeah, I was just going to ask, I think we chatted about it regarding this cluster, whether there was any opportunity to do like the next generation sequencing to help like identify the clusters that break out, and whether any progress had been made on that.
Yeah, so Matt Baxu's not here. He's proposed that as a project that we'll try and take forward. Essentially, what that will do is when we get hepatitis C positive cases, we'll do next generation sequencing, and that will enable us to sort of back trace, if you like. So it would be good, I think, on the back of this, we can see how well partnership working with health protection can help identify and work with clusters. And we know that health protection are also charged with increasing their output in relation to hepatitis. So I'd encourage you locally to try and pick this up, and that sort of forward identification of clusters. But the next generation whole genome sequencing, you might get a report saying, oh, this case and this case are linked. And then you'll be able to say, oh, okay, well, let's go and have a chat with those two individuals and see how they're linked, and see if there's anything more that we need to do in order to investigate that cluster. So it's something we're hoping to do, but I don't think we've quite got it over the line yet.
Can you just say one thing that is really important? I forgot to say it. The information I had from all of the people I caught up with, they very aware of the needle exchanges, everything. They know the ins and outs of it. It was the nature of the drug, the crack cocaine use. They were having to pool money, pool their resources, and they were using frequently, and they were using in large groups. So it was all about the drug, I suppose, from this point of view. Sorry.
Yeah, and I'm quite interested to find out
I'm not telling you.
why we haven't got time for it now, but why there were 10 people who were negative. That's interesting, because, you know, what were they doing which was different potentially? And of course, it's a very hot situation as well. So being negative might just mean you haven't had time to incubate and develop yet. So yeah, very interesting. Thanks, Nikki. Thank you. One thing I just keep forgetting to say is that I'm a prolific non-tweeter. But if anyone is able to tweet anything, because I know that's popular these days. So if anyone feels like highlighting what's happening, that would be great. There's one other thing that I've got to say, but I've forgotten what it is. So I'll do that hopefully after Jim has given us a talk.
First things first, which version is this?
It's the one that you sent very late.
That's okay. Before Delif tells me off because I have to take full responsibility. There was a typo on the one, and she was like, "Don't you dare share that." So I'm standing here now saying, making sure that we get the right one. Hi everyone. Okay, so thank you to whoever nominated me to speak at this event. I found out when the agenda was sent through to me saying, "I'm glad you've agreed to speak at this event." So here I am today. And the title was given to me as well, but it's a great title, so I'm very happy to speak on that. So I'm Jim Henson, I'm the Alliance Manager for Cardiff and Vale Drug and Alcohol Service. And I wanted to start this actually by saying that this piece of work started before I took this role, and my relationship with Gilead started before I took this role in Cavdas. And I think that's a really important demonstration. And I'm not here to talk about numbers today, I'm here to talk about developing partnership working, building trust, and all the values that Cavdas and how that's fitted into that. But this journey did start beforehand. Before Cavdas even existed, Gilead reached out to me in a previous role and said, "There's a piece of work we want to do. How can we work together?" And it was something that I said, "Well, that sounds really great. I think Cardiff would be an amazing place to do that because there's already somewhere to base that on. There's already some great personal relationships in place. Let's wait and see what happens around the alliance in contracting." And as you all know, hopefully by now, the result of alliance in contracting has been Cavdas. And unbeknown to me, when I first started this conversation, I'm now the Alliance Manager. So none of that was planned, but here we are. So that's where this started. Okay, so alliancing is about bringing organisations together, and I wanted to start by talking about alliance values, and more just to point out that it is about sharing our experience, looking about how we can innovate differently, and collaborating and co-production. We all talk about these things, but alliancing is about embodying that in everything we do day to day. It can take a lot longer to get things done, but when we do them, we know that we've got everybody on board from day one. And this partnership presentation is really about how we feel in Cavdas that we worked with our partners to do that mapping exercise in a totally different way than I've ever experienced in my substance misuse work in history. So as part of Cavdas, when we launched Cavdas, we took staff from across Cardiff and Vale from 9 different projects from about 7 or 8 different host organisations to bring them all into one service. And as part of that, we reviewed all of their job descriptions. And it's something we often forget. We focus on patients and service user care and all of the amazing presentations you've heard today around the data and what that means for the individuals that are in treatment. But for lots of the staff that work in substance use, they have an admin role, or they are cleaners within our buildings, or they are dealing with stock control, or they're dealing with referrals, and they're very kind of like not frontline facing, or they might have a structured counselling role, or they might be working remotely and they since COVID and not come back into the office. So recognising that there were 9 different cultures that we were bringing into play, and how we could establish from day one that the expectation within Cavdas was that we were going to support BBV hepatitis C elimination and BBV testing. And so we put this statement into everything from consultation, into job descriptions, and into our launch, and we continue to do that. I want to share with you our pathways because they can seem really like, whoa, everything about this. But in Cardiff and the Vale, it's a whole age service. And that's the message here. And it's a harm reduction service. So for us, we launched from day one with all of our staff. And that was the message that we like to share, that BBV testing is embedded, and we want it to be embedded in every element of the service. And that is a change from the past. Strategically, people like to say, no, it isn't. But the reality of launching a new service and taking on board 9 cultures showed us that that's the biggest challenge. And our values of being honest and working together and candor about that is to admit that that's the challenge, is how do we embed that harm reduction in BBV into every element of the service, and including our CYP pathway. And that will make more sense when we talk about next steps. So workforce development is a large element of Cavdas, which is about supporting our internal staff, but also sharing that externally. And one of the things that we've done within this mapping exercise was to pull together a best practice conference a best practice conference in November. I was about to say October then. It was in November, sponsored by Gilead. Thank you very much. You will see this little statement at the back for those of you that are watching this online, bringing through people from all over Wales to share their best practice. to tell them what we've done in CAVDAS around mapping our services, but also to say, but what works for you elsewhere? And that for us is part of that workforce development, is supporting how we can all share what works for us. We can't all do the same thing in every area, but we can all learn and get ideas from each other. And that's being honest about what's worked, what hasn't worked, and what our challenges are. And I think sometimes it's a struggle to admit those things within services. So it's great to see that that was well attended. Some great ideas came out of that. And one of the achievements of that was around the support, I believe, that we now have from Welsh Government and from our colleagues to have a service provider forum to look at how we can implement best practice. We can look at mapping, we can look at micro-elimination, we can look at all of the barriers that we have as providers, third sector or private providers, and how we can link in with our health board teams. So that change, that recognition has been really, really exciting to hear, and the buy-in from our colleagues across Wales. So our mapping exercise had two elements. It had a testing pathway and a treatment pathway. So looking at CAVDAS whole age, there's homeless and outreach workers, there's kind of the traditional open access, we deliver specialist needle exchange, it's Cardiff and Vale, it's workforce development, it's counselling. There's just so many different elements of the service. How do we make sure that everybody is there? So this is what we mapped, and this is what we've committed to ensuring happens in CAVDAS. And we've launched that with our staff, and we are implementing that. We're not there yet. That's my candor. That's my, we're not there yet, but this is what we are telling everyone we're committed to doing. So looking at it, we did this piece of work with our colleagues from HEPC Trust, amazing at every step of the way, with our colleagues from Cardiff and Vale Health Boards, with Dell, with our public health colleagues, with our commissioning team colleagues, with Gilead there to support us the whole way, learning from how they've done that in other areas. It was a really big thing to work out, drill down every element of the service for all these different parts. What happens when someone who's homeless in our prescribing element of CAVDAS versus someone who's accessing structured counselling online? What happens for someone who walks in the door and has a brief intervention and we may never see them again? How do we link in with our colleagues in Cardiff and the Vale to make sure that we're trying to do that? And how do we set ourselves up so that we can do micro-elimination, small targets, so that we can work in those small groups, and so that we can contribute to our KPIs across Wales? So that was the aim. It's the right one, Dal. 2 weeks. Excellent. 2 weeks from test. What we did acknowledge, sorry, a bit shorter, yeah. What we did acknowledge was that there's a lot of duplication, and that was a massive feedback from our staff. NEO database, case management systems, BBV trackers, because everything doesn't do everything we need it to do. And to be honest, that's my message here, is that you must all be experiencing that, is that it is frustrating for our staff, and trying to get buy-in from them to say, well, we expect you to record it here as an intervention, but we also expect it on the NEO database. But then how do we do the kind of audit of the cases? For us, uniquely in CAVDAS as well, we have a commitment for one database across the service, but at the moment we're working with 7. So that's really hard to then change that culture and to change that ability. So these are all things that for us, mapping what do we expect is not as simple as just saying, put it on the database. It was a big piece of work for CAVDAS. Making sure that we had access and that our buildings were available for our colleagues in the health board team and for the HEPC Trust. One of those challenges is that one of our buildings that's quite heavily used now has got planning restrictions on it, has got limits on things that we can and can't do in that building. And we had change of buildings that we were moving. We were reorganising where our staff were based, integrating teams that had traditionally in Cardiff and Vale never ever worked from the same building together. So for us, just saying something like everybody that walks through the door, whichever part of the service, needs to have a test, is a really big commitment and something that we're really proud of achieving. Okay, our treatment pathway. Obviously, a lot of this is about what's achievable from our health board colleagues' perspectives, how they can support CAVDAS to achieve that, how the HEPC Trust can support us, how we can look at storing our meds, how we can look at making sure that communication's there. And as you heard earlier, it is all about communication, making sure that the right people are doing it. It's great that 80 members of Cavdas staff might know the number to ring Del. Going to pick on you because you're in my eyes there. But actually, that's not going to work in reality. If we get this going as we want, 80 people ringing her all day long, she can't do her job. We need to have something in place, which means that people get real-time response to their concerns and queries, and making sure that the management plans actually reflect where we are with the service users. Some of our staff are out and about marching the streets all day long. They're the ones that can help track down these service users, whether they're in treatment with us or whether they're in treatment with another agency within Cardiff and the Vale. How do we work together? So that was reflected in there. Another part we introduced was our dried blood spot test declined form. So we co-produced this with our staff and with our partners to say, what do we need in Cavdas? And we've had booklets printed. And for those of you who've been around as long as me, you might remember when TOPS were launched. I hate saying that word, but you know, the concept of actually when you're trying to launch something, trying to say you either do the test or you fill this out and you bombard your office spaces with those. We don't want bits of fluttering paper, so we printed them in notepads, you know, that you can just pull off the other one. They've been delivered now, so they're on their way out to all of the buildings. They're already in some of them. So that when the service user walks in the door, it's part of that initial contact. It's there in front of them. They can visually see it, and so can the staff, so that we can manually collect, go back to that old one. We've also got the databases. We needed to look at our culture from every aspect, our data culture, our paperwork culture, our how we interact with our service users culture, everything. We had great testing going on in some elements and not so great in others. So we want to make sure we're addressing every possible angle of how we do things. Oh, and everything's in Welsh, by the way, but I haven't put everything up here. So that's part of our Cavdas steps. So next steps before I get chucked off. The Wales-wide Server Provider Forum. So I know that you've all eagerly been waiting for that. We have had a change of our harm reduction lead. I'm really pleased to announce that Laura Cook has come into post as our harm reduction leading Cavdas now for the Vale of Glamorgan. Will be leading on this with our staff. Thinking about the micro elimination, how we work with our colleagues to record that, to evidence that, to see what we can do with that. And our CYP. We want to innovate and we want to challenge. That's what Cavdas is about. So we've already started the process with our young persons team. They are so enthusiastic. It's a pleasure to work with them, and so are our health board colleagues within, you know, the young person services, about how we can get BBV testing into those most controversial areas. We know we're going to be challenging stigma. We know we're going to be causing ruffles, and we know we're going to be asking difficult questions. But that's something that Cavdas is okay to do with this, and that's our commitment. Partnership working. We welcome any of you who are working in Cardiff and Vale or anywhere to come and work alongside us, to come and join us on our outreach van, to come and join us in our buildings. How can we deliver this together? That's absolutely great. And innovation for access to testing and treatment models. So we're constantly talking about the CEPC machines and how we can work with different applications and different ways of linking in with staff. Yeah, the co-location and our have I put pictures? No, I didn't. Yeah, so our harm reduction van. So we soft launch in the last quarter. It's out about 2 days a week at the moment, all the time. Various different events, but also outreach to those groups in different community centres or in hostels that need it, and very responsive, asking if we can go there. And then specific health awareness days where we've had our partners from the health board coming out on the van with us and the HEPC trust. We also have arranged for the insurance so that any partner agency who wishes to drive the van, they just have to fill out our insurance application form. And as long as they're over 25 and don't have loads of tickets and all the rest of it, then basically they can drive the van and take the lead on taking that out. So that's all in place and being used. So that's our mapping exercise, and I hope I've done that justice to Gilead, HEPC, and
Amazing. So then, Jim. Oh, just in case there are any questions. Yeah, probably got time for one quick question if anyone's got one.
late starting though, wasn't I?
You were late
Yeah.
starting. Yeah. You ran perfectly to time.
Thank you.
Yeah. Okay, so I think
No
we'll
question.
probably want to catch up with you in the break. Thank you. Okay, another mapping talk about mapping out your service and Bazgar Ali. I've just got to get the right one because Baz has very kindly agreed to do 2 talks today. So it's that one. Yeah, perfect.
So I'm Baz. I'm one of the infectious diseases consultants at UHW. And when Brendan left Cardiff, I became the infectious hepatitis lead. So I got donated this, and as part of like taking over the service, I was asked to support writing the recovery plan after COVID with Public Health Wales. And what I realised was that I don't have very good grasp of geography, but I also really don't have a very good grasp of like how all these individual services that actually loads of you are working in work together. So I know we've talked lots about microelimination in the meeting, you know, working in these like small pockets and, you know, working really hard to clear infection in those small groups. And there were all of these like names bandied about, and I just didn't understand how everybody linked in with everybody else, but the same names kept reoccurring. So on paper, it looked like there were hundreds of services, but then there appeared to be just Dell and Lol and Sarah dishing out HCV treatment. So I didn't understand what was going on. So as part of the recovery plan, I decided that we needed to have a good understanding of how our HEPC services were being delivered. So I produced this map. So on my own, and I don't live in Cardiff, a lot with the help of the internet, but this is what's been published on the Public Health Wales website. So it did get checked, so presumably it was quite accurate. So I segregated, when I did the mapping, into organisations to and this was useful for me, and it may be something that you might want to redo to do in your own service, maybe in a different format, but this is how I did it and I found it useful. So I organised it into NHS and non-NHS services because there's lots of like partner organisations or third sector organisations that work with the population that we're like particularly interested in and that are living with hepatitis C. So, and then within the NHS, we have this arbitrary break between primary and secondary care. But obviously the patients like flow from one to the other, usually seamlessly. So I separated into primary and secondary care, so I could see who was providing what care. And then the non-NHS organisations are like a massive group of people, which is the thing that I found quite difficult to get my head around. So hostels are very important within Cardiff and Vale because lots of the people that we are trying to get to have testing and then hopefully to eliminate their hepatitis C infection or get Hep B vaccination into are accessing hostels, whether they're living in them or not. They often are using the facilities that hostels provide, and they use them as places of like safe refuge at times when they need them. So I mapped out all the hostels that are within Cardiff and Vale, and then they're the actual other organisations that are relevant to these populations. So justice and prison services, which include probation and prison itself, the homeless outreach teams, the needle and syringe programs. I think CABDAS is in there somewhere, the Hepatitis C Trust, and then things that you might not think of traditionally as groups there where you may access people that are living with hepatitis C. So gyms, so weightlifting gyms. So there's not been much work done with that group of people in Cardiff. Maybe in other places there may have been, but they are people who are using recreational drugs for differently to the way that our homeless people may be using recreational drugs. And we're not like targeting them, but they are actually really easy people to target and engage into sort of health interventions. Places of worship, I think there's a talk later on coming up from somebody who's done some work in a mosque. They're not because religion defines your disease, but more often religion is a reflection of epidemiology, and you know there may be lots of people, for example, from Southeast Asia who are attending particular types of places of worship. And then the other group that we talked about was community pharmacies, and I think Paul's here somewhere, although I can't see them quite now, but we've done lots of work with pharmacies to sort of like engage testing and treatment in those, and they are like a massive number of organisations, and some of them are single branch organisations, but some of them like Boots or Lloyd's Pharmacy Group, you know, they have lots and lots of specific pharmacies who are all providing services, and pharmacy was so big that I mapped pharmacy services on their own, and it's the ones with the red circles around are the ones that have got active needle and syringe exchange, active needle and syringe exchange going on at the moment, and then the ones that are purple are the ones that had been mapped by that had been commissioned by the health board to provide testing and were active. So you can see that there are some with red circles around that haven't been commissioned. So they're like really, really easy hits for the health board to sort of like go in and commission those particular sites to do testing and potentially giving out treatment. So it's really easy to see in a pictorial way, like, you know, easy targets that we're potentially missing. And then like it was very, very short. And then last thing was like looking at high risk populations, mapping out your high risk populations. And we discussed lots of these people, but so things that we haven't discussed. So male circumcision that's being performed outside healthcare. So that is like is an important risk, and that's happening in certain communities. You may think, oh, it's not happening now, but actually it is, because it's really difficult to get circumcision done on NHS services without a medical need. But for some people, religious, from a religious perspective, it's, you know, like very, very important. So those people will access that service through other means. There are other people, you know, who may have been victims of female genital mutilation. They won't be going to their GP to discuss that. Is something that happened to them, you know, many years ago, but they are at risk also having been exposed to hepatitis B and hepatitis C. So it's not always communities that we're already thinking about, and I think we sort of need to like think outside of our box. So I found like doing the mapping exercise, for me, I did this mostly for me because I found it really useful, because I didn't understand what was going on before, and for me it was about getting my ducks in a row so I could understand like what I needed to target, because before I felt like my ducks were absolutely not in a row.
Any questions for Baz? Obviously hugely embarrassing for me, because I've been running the service for a long time, and about a week after I left, Baz had put it all in order. Baz, you got a question coming from Josie.
Please, so I will be in touch with.
Has anybody else done any like mapping like this?
I was just about to say thank you very much, because I explained all that thing, so did the same thing.
Yeah.
Thank you very much. So I found it really helpful for me as well.
It's the thing that when you go out there, you realise actually how many agencies are out there supporting individuals. So it's like layer upon layer of services to engage with. You just got to identify and find them.
And they all have like all these acronyms, and you like don't know, like, I mean, you don't know what they stand for, and then there's no chance of knowing what they do.
Yep.
Yeah, just in the Lisa's not on stage, which we have actually really useful as well for other elements. So, for example, COVID vaccinations, when we wanted to think about our hospitals in particular, our housing associations, where we might. So it's really, really useful exercise.
Yeah, excellent. Yeah, Andrea.
Between all liver disease, service provisions of each for hospitals in this 2025, and so just to let people know, see this can be accessible to everyone, this information out there.
Okay, thanks. So if people couldn't quite hear that online, there's a similar exercise happening in the liver disease LDIN, I forgot what it stands for already, to map liver services. And I suppose what would be nice, isn't it, if we could map the service provision, if we could map that across to what Matt and Aaron showed us earlier in terms of micro elimination, because then we could start to see those circles turning a micro elimination colour, and then mapping it with liver services so that it's all interlinked. That would be a great achievement. So yeah, thanks, Baz. Thanks very much. David Wing. David, I don't think you're using a PowerPoint, are you? I think you wanted some light.
Yes. Sorry, I can't remember what I had for breakfast, so I need notes and I need light in order to read them. First of all, apologies. I apologise for England doing better. Honestly, I do. I was going to go straight into talking about the Huggard, but I spoke to a couple of people earlier who said, "What's the Huggard? Never heard of it." So just very quickly, there was a local guy called Bob Huggard who many years ago donated £200,000, back when it was a lot of money, to create a day centre and hostel for Cardiff homeless people. So it was initially called CASH, Cardiff Action for Single Homeless, I believe. But then became renamed the Huggard after Bob Huggard died in his honour. So it's been rebuilt a couple of times since then. We're based just around the corner by Cardiff Central Station. It's a day centre and a hostel. And we've also now inherited T Tresillian Hostel, which used to be a council hostel, but they asked us to take it over. So the day centre is open from 8:30 in the morning till 7:30 at night, and that's where the main needle exchange provision is. But it's a 24-hour provision, because when the day centre shuts, there's a smaller version of the needle exchange in the Huggard Hostel. The day centre itself is open to Huggard Hostel residents, T Tresillian residents, and street homeless. But the needle exchange is open to everybody. You could come from any other hostel. You could be permanently housed, privately housed, whatever, because the theory is that harm minimisation, harm reduction should be for everybody. The equipment we give out, obviously, it's the variety of syringes, needles, one-hit kits, sterile water, Vitsi, etc. But then that comes kind of with its own problems, because the Huggard NSP is well known. We've got quite a good provision. The staff are very well trained and knowledgeable. But the other side of that coin is a lot of the local residents and a lot of the local councillors believe that we're actually attracting problems to the area, because the other side of the coin of having a well-known, well-stocked needle exchange is, are you attracting drug dealers and drug users to the area? And so to counter that, we'd say that, for those who aren't aware, Cardiff Docks, Cardiff Bay and Butetown have historically been the areas to go to buy drugs. So for those of you who are staying here tonight, Cardiff Bay, Cardiff Docks, Butetown, the areas to buy drugs. So it's not really a case of attracting people, but it's about putting an NSP where it's needed. So it's actually serving the community that need it most, and specifically the local homeless community who are injecting drug users. Substance misuse. I'm teaching Granny how to suck eggs, but I've got it in my notes, so I'm going to read it anyway. Substance misuse can be both a cause and a symptom of homelessness. And obviously the stress of living on the streets can increase the use of drugs as a coping mechanism. Some people experience homelessness because of bereavement, relationship breakdown, losing their job, maybe going to prison, and when they come out of prison, they've lost their accommodation, physical or sexual abuse, mental health issues, the variety of reasons why people become homeless, and a variety of reasons why people then use substances to try and deal with that. A strong harm reduction team within an NSP can ensure that the clients who come there receive the best harm minimisation advice possible, as well as the sterile equipment that they need, and referrals for those who may actually be seeking abstinence rather than just coming for needles and syringes. And also there's the health impact to consider, where the strain on the NHS and finances can be alleviated by the use of NSPs. Plus it potentially prevents fatal harms, obviously why we're here today, such as the transmission of bloodborne viruses. And one of the main factors, obviously, in the transmission of hepatitis and HIV with the clients that we mainly deal with is shared injecting equipment and reuse of needles and syringes. Reuse could be because they haven't got as much equipment as they thought they were going to need because they're struggling to hit their veins, issues accessing an NSP, or maybe they've got nowhere to store the equipment they know they need because they're homeless and all they've got is the clothes on their back. And the same also applies for the use of crack pipes, because as we know, that also spreads hepatitis with shared use. So the HUGAD staff have good understanding of the equipment dispensed and thus offer to enable safer injecting advice to reduce potential physical harm and infection. We can advise around possible overdoses and how to treat this. We have a lot of overdoses. Fortunately, not many fatal ones, but we deal on a pretty regular basis with clients overdosing. One of the reasons lately that this has been a problem is because of the poor quality of the heroin. And so various adulterants are being used just to boost the quality of the stuff they're buying. We've been alerted, obviously, via Gareth and Public Health Wales about the increase in nitazines being seen, not just in heroin, but in benzos as well. And one of the big problems we have is polydrug use, where they're not getting the kick that they want out of their drugs. And so they're taking heroin, crack, benzos, MDMA, they're taking everything just to try and get the way that they want to feel. But the problem with that is with polydrug use comes unexpected side effects, especially with adulterants. And when they go down, that's when the staff have to rush over. Obviously, all naloxone trained and confident. And also we've got a first responder on site who's trained in the use of oxygen, etc. When it comes to, I'll try and focus on the BBV element of it. When it comes to BBV, another reason the HUGAD is well known is because we historically have tended to take in a lot of the clients who have been evicted from other hostels. So we deal with a lot of chaotic, challenging behaviour. And that's why sometimes it's so hard to do a BBV test when you've got someone running into the exchange, demanding the needles and pins that they want, and you're trying to engage with them, but they're yelling at you and they want to get out and they're clucking. And this is where it's been great for us to have the BBV nurses come in. So obviously we've had Sarah and Lorraine historically who have come in. Ryan and Morgan, I've got to give a woo to, because they're great. We talked about their HIT testing. They've been in and they've even gone around the hostels and knocked doors to test people. And what's also good as well is that we face so much chaos at the HUGAD sometimes with unhappy clients, that when you've got sort of smiling faces like Ryan and Morgan who are so laid back, we can plot them up in the medical room, bless them, and they know that, you know, they're attracting a lot of the problems away from us and allowing the BBV done while we try and do the stuff around wound care, safer injecting, etc. And also it's good. HEPC Trust are now coming in once a month and spending the whole day, and they're also coming in with their peers. So I'd like to again thank Kieran and, sorry, what was your name? The one who yawned earlier? Andrew. His name's James. He yawned earlier. Did you hear him? And so with us, as I say, we're working with very chaotic, very challenging clients. And so what our staff need is not just the ability to hand out equipment, but it's empathy, because we're dealing with a lot of people who have never encountered empathy from other people before, professionals or otherwise. Whether it's because they've got trauma, adverse childhood experiences, mental health issues, we try and work with them. The staff are trained around trauma and ACEs. We try and build supportive relationships with the clients in order that we can then begin to have the conversation with them. It's not just about giving them equipment. It is about, you know, helping them with their wound care, helping refer them on. We offer other things at the Huggard outside of the sort of the harm reduction team. There are staff there who give out benefit advice, support workers, independent living skills. We offer really good food there, free breakfast to everyone, subsidised lunches. There's always a free option as well for people who are street homeless and haven't got any money. Clothing, toiletries, a safe space as much as anything else, because a lot of these clients, they're living traumatic, violent lives. And sometimes another difficulty we have in engaging is that historically they've had issues with other clients who are coming to the area and they just want to get in and out, or they want to come in and then find a safe space around the back, maybe diversionary activities, or just to chill out from the sheer chaos of their life. I'm aware that but we do a lot of stuff around mapping and motivational interviewing. And in summary, you'll be glad to know, I'll read this bit. In 2004, the World Health Organization said there was compelling evidence that NSPs help prevent the spread of HIV, are cost effective, and there's no evidence of any unintended negative consequences. 2018 study concluded that removing NSPs would lead to a large increase in HEPC, something obviously which we're trying to eliminate by 2030. And a 2019 study concluded that NSPs were among the best investments the UK Health Service could make. Following on from being able to run a successful needle syringe program, research has shown that medically supervised safer injecting centres, or enhanced harm reduction centres has become the term, reduce the risk of drug-related death, halt the increase in Hep B and C, reduce risky injecting behaviour, increase the likelihood of accessing treatment for drug dependence, reduce discarded syringes in public places, reduce public injecting, and do not in any way increase thefts or robberies in the area. This is the way that certainly we in the Huggard, and I'm sure most people in this room would hope, would be the way forward in Wales. Thank you.
David, stay with us. I'm sure there'll be maybe a question or two. Any questions, Jonathan?
It's in Scotland, in Glasgow. We're in talks. Yeah. 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 We've looked at how we could get around legislation. All I can say without revealing too much is the police are in favour because they can see the worth. It will be how to do it, and we're looking at maybe a targeted group, because obviously the local residents, they've already got concerns, and businesses. So to say we're going to have now a room where people can come and inject is only going to increase that. So what we're looking at is maybe a focused cohort, people identified by police and probation as regular drug users who also cause antisocial behaviour, or always in and out of prison, and as such maybe the people who would benefit from a safer injecting centre, and then we'd have to look at the legalities around it, safer operating procedures, etc., etc.
Any other questions? David, thank you ever so
You're
much.
welcome.
Yeah, I appreciate that. Okay, next up, the other half of the dynamic duo, Ryan Davis.
Just pop this way outside, if that's okay. Right, hello everyone. So I'm Ryan Davis, a Public Health Wales National Point of Care Testing Practitioner. The title of this project is Acronym Central, so give me a second. I am part of the point of care testing team based in Wales Specialist Virology Centre. That team is formed of Louise, Senior Biomedical Scientist and National POC Lead, Morgan Cutland, National Point of Care Testing Practitioner, and little old me. So we're a Public Health Wales based team working across all of Wales, providing bloodborne virus screening to multiple areas and client groups using our point of care testing platforms. So in summary, a multidisciplinary team identified 5 community drug and alcohol testing centres. I'm going to start using the acronym soon, across the Cwmtaf Health Board. They were identified to us as a potential place to set up point-of-care testing clinics. This was a testing project which began from July to December, so it was a massive project which took a long duration of time. We started in Bridgends Celtic Court, moved on then to Pontypridd's Dewi Sant Hospital, then to Rhondda Valley's Trialo Resource Centre, Merthyr's Care Hardy Health Park, and Cynnon or Mountain Ash's Ysbyty Cwm Cynnon Hospital. In total, these CDATs cared for around 1,400 patients. Our project goals, all of our project goals kind of contributed towards hitting the World Health Organization elimination targets, at least I hope. So we wanted to set up bloodborne virus clinics in all 5 of these CDATs across the health board. We wanted to offer every single patient working with the CDATs a bloodborne virus test. But with offering every single patient a test, we wanted to make sure we hit all of the bloodborne viruses, not just Hep C. We use the opportunity to provide any bloodborne virus education. So my colleague Morgan Cutler has mentioned the #LoveYourLiver poster. We use that in the CDATs to really reduce the stigma around bloodborne viruses. We really want to establish that there's a lot of different ways you can catch these viruses. We also educated on just harm reduction and new treatment methods, because a lot of people still think that it's the interferon. We also wanted to increase the number of patients with testing within the last 6 months. We wanted to refer all new infections to the hepatology teams, provide dry blood spot training. So I know there's dry blood spot training already going on, but expanding the service so more people can offer the testing. And we wanted to ensure all antibody reactive patients received a confirmatory PCR. And every single test that was performed, we wanted it to be recorded on Welsh Clinical Portal, laboratory information management systems, and the neo harm reduction databases. So we offered a 2-tiered POC testing strategy. This has been mentioned quite a few times, but I'll go over it again. Initially, we screened every patient that was willing with the AuraSure AuraQuick anti-HCV or POC swab. So this was able to give patients a rapid result for hepatitis C antibody exposure within 20 to 40 minutes. Upon obtaining reactive results, patients were then fast-tracked onto a CareFit platform where we took a little micro container of blood. In the top middle picture there, you can see the micro container. Using 100 microliters of blood, we could provide an active hepatitis C infection PCR test within an hour. Along with offering the POC testing, we wanted to offer dry blood spot testing as well. This ensured that we was testing for hepatitis B and HIV at the same time. I had to get myself in the presentation as well, and James as well. So, as what we routinely offer in our point-of-care testing clinics is the sales pitch, or we use our wonderful charm to try and encourage people to come and have a test with us. With the CDATs, they had a unique thing which we wanted to exploit, which was the client lists. So with those client lists, an appointment letter was sent to every patient for each CDAT. This was the first time using the appointment letter for us as a point-of-care testing team. We offered patients a non-invasive liver screening diagnostic test. We did highlight that results could be obtained within 20 minutes, and the number of patients we booked in per hour during our times at each clinic was determined on the space that we was allowed to work in. During the testing period, we did want to engage with new clients, so we didn't just say to people, you have to turn up here or we're not going to test you. We wanted to see newcomers, and we was also allowing patients to change their appointment times if they needed to. Another benefit of having the client list. With the assistance of CDAT staff, we performed what I'm calling a localized look back. Please don't copyright me on the look back name. But with this, we analysed patients' BBV testing history with the help of the CDAT staff. This information was collected using laboratory information management systems. A benefit of using this was that any tests that sometimes go missing on Welsh Clinical Portal, you're looking for results and you can't find them. That's sometimes because something wasn't entered correctly or there wasn't an NHS number available, so we could find those as well. So this exercise allowed us to select the correct test for each patient. It was allowing us to fast track certain patients to PCR upon coming to see us. It also shortlisted several patients who needed testing for potential active infections. This list is now in use by CDAT staff. From analysing patients' bloodborne virus testing history, several useful statistics are now in use by the CDAT staff. We didn't have access to Welsh Clinical Portal during the exercises, so we weren't able to tell if there was people having been referred already for their hospital appointments or currently on treatment. So there's my lovely dummy with Blog Central. They were all categorised into different tiers based on the history that we found. So if a patient fell into the green category, their last test was 3 times non-reactive. They have up-to-date testing within the last 6 months. A red was a potential active infection. So the last test on limbs was either a positive PCR with no negative PCR to follow, or an antibody reactive with no follow-up PCR. Grey was no previous test on system. So as far as we can see, they've not been tested for bloodborne viruses. I do want to highlight that results pre-2014 aren't available on limbs. And orange signified previous infection/exposure. So these patients have had a PCR at their latest test, but they should, as we claim, should have antibody reactivity. So we would fast track all orange and red patients upon coming to see us straight to PCR testing. So this was a little tick list we had to go through before going to every single CDAT, establish contact with the teams at the centres, meet the respective staff, work through the client list with the help of the CDAT staff, visit the clinic to determine the most appropriate working space, determine the number of patients we could test per hour. This usually fell in around the 10 per hour mark, so we were very busy bees. So we arranged suitable testing dates for the CDAT staff, and I really want to try and highlight this all the way through. This task wouldn't have happened without the help of the CDAT staff. So they were able to set up the letters, print them out, and send them to all engaging clients. We allocated our equipment, brought them to the centres, and began testing. Now we'll fast forward right to the end. So this was the post-project analysis. The graph on the right signifies in orange the amount of patients we tested, and in red were the total clients that were on the books in each CDAT. So we started in Bridgend, working for 8 days, booking in 12 patients per hour, testing 112 people in total, and we found 2 active hepatitis C infections. Both of these patients have completed their treatment from the community with the help of Ali Gudgeon. Next up was Pontypridd. We worked for 6 days in total, booking in 10 patients per hour, testing 110 people, finding 1 active infection. That patient was admitted to HMP Swansea and treated there. Next up was Rhondda, where we worked for a whopping 9 days, booking in testing 164 people in total. We found 5 active infections. 1 has completed treatment with an SVR outstanding, 1 has started treatment, and 3 have repeatedly not attended their hospital referral appointments. So no matter how hard we try, we just simply can't get them to turn up to the hospital. Next up was Merthyr, where we tested for 5 days, booking in 8 patients per hour, testing 88 in total, 0 active infections, which is fantastic news. And last but not least, a little Christmas treat. We worked in Ysbyty Cumcanon Hospital for 4 days, booking in 8 per hour, testing 77 in total, finding 2 active infections. The 1 patient was already known to the hepatology team and already going through referrals, and the other one is currently on treatment pending more referral appointments. So first up, I'm going to talk about the results of the appointment letters. So in total, we tested 553 patients over 32 days. So that equates to 39.56% of the population we found on the CDA client lists. Attending for appointments, so 462 of the 553 turned up when their letters stated. So they received their letters, they turned up at that time and came to see us for a test. Early/late, we used our charm. We had massive help from CDAT staff. They received the letters, but they couldn't attend on the day, so they were convinced in when they were here or when they were there. Walk-in/new, these were people that didn't receive the letter or they were brand new to the clinic. Through the help of CDAT staff, we were able to encourage them to come and see us. So the big take home from this is the fact that the percentage of patient attendance linked through the appointment letters was around 84%, which the pie chart shows here as well. So for those 553 patients, we performed 1,104 tests. As you can see on the graph, that's the split of all the tests per individual site. The table says it as a whole. With dry blood spot and POC testing, it was kind of uniform and very identical, and there was only a few differences with certain patients who didn't want specific tests. Antibody results, 75 patients out of the 553 were reactive or positive for hepatitis C antibodies. So 13.5% of the caseload that we tested were reactive for Hep C. There's such a disparity between POC and DBST. Because we used the look-back exercise, those 58 patients roughly received fast-track testing due to the look-back exercise. So by utilising that, if we offered them our routine POC testing strategy, they would have been screened for antibodies, left the clinic, and we would have had to potentially call them to come back and visit us for a PCR. So in that sense, we didn't miss those patients by fast-tracking them on. We found 10 active infections in total. There's a difference between KEFID and DBST PCR. The one patient we already knew, so we tested just for DBST, just to test for Hep B and HIV. And the other patient, we offered our traditional pot testing pathway because the look back exercise gave us no results. They was reactive. They left the clinic. We tried to call them to return. They wouldn't answer the phone. So by referring this patient to the CDAT staff, they bled this patient via venipuncture. They were then confirmed to be an active infection via the gold standard testing method. So these are some stats from pre and post project. There's a little bit of method to my madness. So each group of numbers was collected from July, August, September, November, December. The 5 of them come together then to make these stats. If anyone wants me to explain it, I can later on in a bit more detail. But the patient number always fell around the 1400 mark. This varies due to a lot of unknown statistics. I imagine the client load number is like an elevator, it just lifts up and down all the time. So patients with a full BBV screen, beforehand it was 838. After the project, through the testing from ourselves and CDAT staff, this was increased to 1036. So now 198 more clients have received a full BBV screen. Patients with no recorded tests, that's what we can see from using LIMS anyway. It was 367. That's been reduced to 253. So 140 clients have been screened for bloodborne viruses with no prior testing history. Patients tested for bloodborne viruses in the last 6 months, it was 257, it's now been pushed up to 658 with testing from CDAT staff and ourselves. So that means that 47% of clients at CDAT now have up-to-date testing. That was at the point in December where we finished the project. So looking at the entire client list from the look back exercise, 245 patients showed current/previous exposure to Hep C. So we managed to investigate 115 of those cases, but putting that number against the total client load means that 17.13% of patients engaging with CDAT have been exposed to Hep C. So if we put that in a more sensible number, almost 1 in 5 patients have previously or are currently known to have been exposed to the hepatitis C virus. I just want to say as well, we found no Hep B infections and no HIV infections. Don't want to miss that out. So to reflect on it all, the help from CDAT staff was paramount to the success of the project. The appointment system definitely had its successes. I think the 84% of attendance speaks that. It does have its limits. Obviously, it only applies to areas where there is a client load or patient list. And obviously, there are certain patients which will never receive these letters. Some of them will open them and they'll throw them straight in the bin as well. So you can't get them all with this method, but it is certainly a method to hit them. There's an advantage to booking a large number of patients per hour. We reduced our time in each clinic, so we really enforced that high intensity test and treat, and we didn't get in anyone's way for longer than we needed to. Let me just check. Yep, and we also avoided the challenges that certain patients face with attending their appointments. Challenges of the current treatment pathway. Sadly, we are still trying to reach those 3 did not attend patients. It's really hard to get them to turn up to their hospital appointments for some reason. I'm sure we all encounter that issue anyway, but only 2 patients have refused to have a test upon attending the appointment. So they came to see us, they saw what we offered and they said, sorry, I don't want this. I've had it recently, I'm not interested, and they left the clinic. Only 7 patients didn't have a DBST sample taken, which is 1.3% of everyone we tested, which means that DBST is just a widely accepted test now. We offered a night slot in Merthyr, as during the time we were there, they offered a late clinic to cover people that can't always attend the 9 to 5 appointment schedule. There's a lot of promising potential of using the look back exercise. It does only apply to places with client lists, but we were able to select the appropriate test and fast track people to PCRs. I feel like we enhanced our care pathway because we understood the patients that were coming to see us. And also as well, no one was missed for, oh, that's later on, sorry. And then obviously by doing the look back exercise, CDAT obtained a lot of statistics that they're now using to benefit the patients. We was able to provide dry blood spot training at multiple sites. So now the dry blood spots are being applied a lot more frequently across all of CDATs. Every antibody reactive patient received a confirmatory PCR. So I just want to say we didn't miss anyone that flagged up as reactive. They were confirmed via some method. And promising news for the future of CDAT, they've now purchased a fibre scanner in Cwmtaf, and I know a lot of people are working really hard to develop some prescribing nurses directly in the CDAT. Just This list should be about another 5-6 pages long. I can't thank everyone in a quick point, but CDAT staff from all sites, thank you so much. Dr. David Samuel, Nikki Palmer, Neil Thomas, all Cwmtaf hepatology nurses, the POC team, Jonathan Evans, Greg Robinson, Wales Specialist Urology Centre, the GLAM staff, Dr. Brendan Healy, Paul John for prescribing treatments to these patients, and so many more. Thank you for listening. Thank you very much. Everyone.
Any questions for Ryan? Josie?
API 6 historically and over the last 8 years has always indicated from TAP that they have around 50 to 60% declining of testing. So what you've achieved is absolutely incredible, and yeah, really turned it around. And it really does go to show that. Do you have any insights in how you turned that around? Because is it a historic just decline assumed?
I think I can answer that because they were there actually asking and doing it. I think what we see historically is, we get reporting saying we assessed 1 billion people and 2 accepted the test. It's bullshit. That's oh yeah, great piece of work.
Thank you very much. Thank you. I think you've got another question. You're getting a lot of applause. Gavin.
Yeah, absolutely. Yeah.
Thank you.
Thank
Yeah.
you very much.
I should just also say I don't know why my name is on the credits there because I did absolutely nothing for that project. But thank you all the same. Nikki, it's you again. Are you expecting a second one? Are you expecting a second one? Have I got your slides somewhere? What was it called? Can you remember?
It was
Okay. Sorry about the brief delay, but Nicola Reeve is now going to talk to us about closer working with the health protection team, including the re-engagement project.
So sorry if this feels a bit like deja vu. It is me again. So this is just a quick chat. It is. I won't take the full amount of time, she says. Yeah, no, I know. It's just the work we've done with the health protection team, really, that's come on the back of the cluster indicate that we picked up in Llanelli, and it was because I sort of went from the last time, lessons learned, get public health involved quickly, and the help and support was coming from all directions. And I think that's what I wanted to get across to people, is that there is so much help out there, and one thing's led to another, to another, to another. So it's been brilliant. So they're providing support with me trying to contact trace people, find patients as well. So with the re-engagement, I didn't have any admin support at the time, so they sort of took everything off me. They were sending the letters, they were checking with the GPs. They were like, that's what we do, that's fine, just pass it on. And I intermittently felt guilty. I thought I should be doing this, but they said, no, we'll do it. And they did it really well. They were linking back, they were letting me know what was going on. The health protection nurses, as I said in the last talk, were coming to the drug service with me every week to do the vaccinations for Hep B and Hep A. And that now is rolling out to the whole of the health board. So they're going out to the other BBB nurses, to their outreach clinics. And what's great is that they've also gone, so-and-so should have come in this week. They haven't come for their second vaccine. They give them a ring. Are you coming in? Oh, it's not easy. It's not a Can we come and do it at home? So they've literally gone to people's homes. So it's been brilliant. I'm thinking, oh my God, this is just amazing. They work from the vaccination centre, so they're telling people, do you know what, come to the vaccination centre, we can do it for you there. So the options are vast. Instead of me going, do you know what, I've got this one afternoon once a week, this is the channel I can provide you. They've got a lot more they can offer. They've done some BBV training. I think Del, they sort of sat on one of your trainings that you did, a lot of them, and they said it was brilliant. I said, I'll tell her. Her head is big enough, I don't need to tell her. But yeah, so when they've done the training, they're really enthusiastic, they're really keen. They've sat in and learned a bit about dry blood spot testing. They've got the grab bags. They go and vaccinate in soup kitchens and places like this. So they've asked the soup kitchens, can we dry blood spot test people if they want it? So we're setting that up. So we're sort of setting out more and more. And this is the health protection team offering the support around this to do these extra bits and pieces. We've also, obviously they can do venous sampling. They can venous sample, and they will do that when it's needed. The particular soup kitchen they've linked in with doesn't want them to do the venous sampling, but is happy for them to do dry blood spot testing. So you sort of go with what they can do. This is on a Saturday evening, so they're sort of outreaching as much as they can. They're really enthusiastic. They're really enjoying listening to client stories, learning about hepatitis C. And for me, it's been an absolute breath of fresh air as well, because I felt it's reinvigorated my enthusiasm into everything. So it's been really good from that point of view. They link in, they'll question things, they'll do lots of different things. We obviously got band 3s who FibroScan. We can FibroScan out in the drug services. So the lead for the health protection nurses said, I can offer you band 3s if you need some extra band 3s to do some FibroScanning, to come out with you. If you want to train them up, Nicola, that you can have them, they want to learn. Let's encourage them to the marvellous, thank you very much. So all of these things are in the process of where we're moving to, which I know from a re-engagement point of view doesn't seem much, but it's a lot when we're moving forward, especially when, you know, I sort of see it in my role now. I've got to look at it is you come to me to be treated, and let's get the testing and that side of things. And if they can be a support around that, the way they're learning, you know, I don't work 52 weeks of the year. Dr. Rees would love it, but I don't. But they could pick up and just check, are you going all right with the treatment, any issues? So they're learning and they're enjoying the learning of it. They're great at identifying that hard to reach group of people, and, you know, to outreach, because they work in pairs. They go out and they outreach to the risks. Obviously risks we take into account all the time. We've done some training with the Wallich staff. So Wallich is different, I suppose, with what they offer. So we've got the dry house in the county where I work, and we trained all the staff there. So they're going to test people. The health protection nurses have also gone, should we come up and vaccinate? So they're sort of, and we can do the flu, and we can do your COVID, we can do whatever else. So it's sort of rolling to other things. It's not just about that sort of hepatitis B. We're thinking of the bigger picture they are thinking of the bigger picture from what their role is. So the Wallich staff who deal with homeless and housing support, who I did a lot with this cluster. We've trained them to do dry blood spot testing as well. So the health protection team now are vaccinating them all in preparation to them doing the dry blood spot testing. So that's been brilliant. So the ongoing work with contact tracing, I'm sending my list up to date again to the health protection team, and they're going to send out letters again and contact again. So it's been really, really good. And from the HEPC trust side of things as well, Danny, the letters went out to individuals. One individual, you don't know that people might have mental health problems. We never know anything when these letters are landing with them. And this individual couldn't get hold of me. The HEPC trust number was there. She rang the HEPC trust and they reassured her. They got in touch with me just to say, look, she's trying to get in touch with you. And I spoke to the gentleman, HEPC trust, who was amazing. But it's just that rounded everything. I just feel like everything's slotting into place, which is lovely. It's really good. So I think it's just that bigger picture. But what I want to say is your health protection teams are out there. Utilise them. They're amazing. And that's it for me. I'm not on commission. I'm not on commission.
Any questions for Delith?
They send the letters out to the GP. So we trained the Wallish staff with Neo, haven't we?
Yes.
But we haven't recorded. No, we're not recording the vaccines that they're doing. But we've got the list that we can. I don't know whether I can send Dan out with their sort of lead there, and they can do that.
About is actually the recording of the happy families and doing like repository.
Yeah.
We've got that we have like a special call for actually looking at video, then actually it can really
Yeah.
because we can.
We've got the database of everyone that's been through. The health protection nurses. Yeah, I can send it to you. And the health protection nurses are automatically letting the GPs know. So we're sort of keeping the sort of flow of the information going from that primary care point of view.
It is the only mechanism.
Yeah, so I can send it.
Yeah.
Send it on. Yeah.
Dan loves a list.
Dan Pitsy. There's some people that must absolutely see an email from me and go, oh, that's Nicola again.
Very quick question. Does every health protection team in each health board have the ability to provide vaccinations? Because this is a real heavy vaccination.
The answer is potentially yes. I've spent my time for the last 12 months trying to, what I call the Siberian approach, keep telling Cardiff what they want to hear, carry on doing what I think is right. And I think they do, but we actually are quite lucky we've got quite senior staff, and I'm dealing with the same 2 or 3 people as a small health. And although I came back for COVID, I've got quite well progressed. They know how we all think together. Other places should be able to do it. They may be different difficulties. My suggestion, just try.
Yeah, there is an opportunity to sort of try and access the health protection teams, particularly at the moment, as COVID has obviously decreased in terms of our demand on our time, and a specific ask from Welsh Government that their time is deployed towards elimination. So
Knowing how they're really keen to be involved.
Yeah.
Really, really keen.
So as Nikki said, the key message is reach out and see if you can get some help there.
There are 2 health protection. There's one next week.
Yes.
There's also the
Health board.
which
Yeah.
are very close. I know who my team is. It's almost seamless. We all know each other.
Yeah.
So I think that's the key, which part of the health protection team. And then the other thing, we've got a big push on for vaccination with measles. So they should be getting people skilled to vaccinate people. I don't think vaccinating is that difficult to train people who've already got a clinical task.
So which of those 2 teams is it? It's the health board team, isn't it? That we. Yeah.
Nicholas being held by, is it Mary and Darren?
Yeah,
We've got.
And Glenn as well.
Do it.
Just reach out to both of them and see how you get on. Yeah. Did you have a question, Nikki?
Just whispering about that. I said, send it over. We do it.
Okay. Is that something I need to announce more widely? So there are STI packs which and how do you access them? Okay, STI packs available via Sexual Health Central, and we'll send out the link. Okay, good. Okay, last talk for this session is Gavin Hardcastle, mosque testing.
Yeah, it makes a change not to be talking about our incentive scheme. I liked Baz's comment that religion is a reflection of epidemiology, and perhaps actually what we were doing here was actually an epidemiological exercise. We were going into the mosques because we're targeting people from high prevalence countries. We'd done mosque testing before, prior to COVID, and all we did was BBV testing. But this time we've gone in and we've made it more of a health event. And you'll see that as time has gone on and we've done more events, it has snowballed and it's advanced. And I think we've got quite a nice model going. Unfortunately, Kazim, our GP, isn't here today, who's an absolute star, and he's really driven the mosque projects forward. So, key theme of the joint recovery plan was increasing testing within high-risk groups and increased case finding and outreach. So that's what we were doing with the mosques. We wanted to engage with people from high prevalence countries of origin through a series of community screening events. And to prevent stigma, we've really run these as health fairs. So Hep B in Wales, it's a low prevalence country for hepatitis B. Most cases of Hep B are acquired outside the UK. Most cases result from migration from high prevalence countries. In Newport, we've got a higher population of the population from ethnic minorities, with about 20% of the population from non-white British / Welsh backgrounds. This compares to 10% across Wales. So community where people's country of origin is from a high prevalence country, obviously they've got higher risks of BBV infections. So the risks include vertical transmission, horizontal transmission through childhood infection, use of non-sterile medical equipment, or procedures. So we wanted to raise awareness of both communicable diseases, so BBV and TB, and also non-communicable. I'm going to move on from that word. Because it was a health fair, we were also doing stuff to support community members to engage with preventative and diagnostic interventions and screening. And it was about strengthening community engagement. So members of the community were active participants with ownership of future care or treatment. So what we did, we held community health fairs in Newport. We worked in partnership with Muslim Doctors Cymru, who were amazing. We had GPs coming from Cardiff to come and help out at the health fairs we ran in Newport. And where the mosques weren't suitable as venues due to size or layout, we used, on the first occasion, we actually used a community centre. And the plan was to hold events every other month over a year, because we've got 6 main mosques in Newport. And think about doing this on a regular rolling basis. As I say, we've not run these as a BBV testing event because of stigma. We've run them as a health fair. And actually, they've been so popular as I've gone through BBV results, I've spotted names that I recognise and realised that person had been to the previous health fair. So they've come back through again. So we're taking the focus off BBVs. Although I have to say, when we ran our first 2 mosques event that we ran just as BBV testing, it was really well accepted. We had like the imam getting tested, and I don't think there was a stigma there. We fought, but there's loads of stuff at these. We had guys doing blood pressures. People were screened for AF, atrial fibrillation, with a simple machine that you grip. They had the BMI taken. They were T-spotted for TB, and in the last event, we were fibro scanning. And they got health promotion advice in things like cancer screening, immunisation, and smoking cessation. And these events have developed as we've gone along. The first one we did in September 2023 was done in a community centre, a multicultural, multi-faith centre in Newport, serving Maindy and beyond. And this was to target the Al Noor Mosque, really, which wasn't suitable as a venue. That was only DBS testing we were doing. It's the royal we, because I think I was somewhere nice and sunny at the time. 32 people were tested. Demand was greater than supply. And when I say bar the doors, I think Kazim actually did. I think he had to lock the doors in the end because I believe they were overrun, which is great. We ran another event in November, Central Mosque, Stowe Hill, Newport. Again, we only used DBS testing, 38 tested. We did actually manage to keep up with it that time. That ran nice and smoothly. The last event we did, we've got a little bit of a pause at the moment, but we are going to do more events. We did the Igra Mosque in Newport. And there we did a mixture of venous bloods. So we T-spotted people, then we just took an extra SST for BBVs. Where people weren't having a T-spot, then we did DBS. We got 43 tested. We actually managed to keep up with demand pretty much. We had the TB team there. We actually had one of the guys from microbiology labs. He was sort of blinking in the light because he hadn't seen it before. I think he quite enjoyed getting out and pressing the flesh. I had my colleagues Joe and Karina there, and they were busy fibro scanning, showing off they're really posh. They've got posh rollout screens with the Gwent liver logo on. So I think Andrew Yeoman was sort of very excited by them because we actually had a consultant there as well, which was brilliant. So great having the consultant there. I had one guy with some gastro-surgical sort of problems who was asking me questions. I'm like, oh, Christ. Go and grab the consultant, and he had a little private consultation. So that was a really good event, and I think that probably reflects what we're going to do in the future. What did we find? Not a lot, unfortunately. Surprisingly, we found no Hep B or HIV. Previously, I think when we've done screening, we've only tested for Hep B and Hep C when we did our initial MOS projects. But this time we've done HIV as well, because why the hell not? You may as well. You may get a surprise. So no Hep B, no HIV. We had one person who was Hep C antibody positive. She'd had interferon before. She was PCR not detected. Brilliant, nice and reassuring for her. And great news for all those attending. You know what it's like, the BBV nurse wants you to have something. Yes, but no, good. Why aren't we finding it? We didn't find any evidence of old infection. Perhaps primary care has sent us these people already and we've treated them. Were we in the wrong mosques? As we say, religion's a reflection of epidemiology. The mosques often have different populations. So you may have a mosque which has a higher proportion of people from higher risk areas. So it'll be interesting to see what we find when we test the other 3 mosques. Do we have the prevalence we might be thinking we have? Perhaps we haven't. Let's see what we find. These 3 days were great. They were very enjoyable. They're really labour intensive. And actually, between the 3 events, we've tested about 120 people. When actually, unreadable that is, in Newport, the population we probably need to be targeting is about 11,000. So it really is tip of the iceberg. Little side, the fibre scanning was very popular. We used criteria so not everybody got scanned. Joe and Karina scanned 44 people. 8 had a raised fibro scan. They've all been offered follow-up appointments. And half of them were non-insulin dependent diabetics. So if you can get your fibro scan there, it is well worth doing. These were the criteria they went through. I'm sure Joe and Karina would be happy to help if you're looking at doing this. Not help as in doing the scans, but advising. We had a mixed demographic in terms of ages and a wide variety of ethnicities. This is across 2 of the mosques. You can see that most people were Bangladeshi, Bengali, and Pakistani. And as I say, if you look at individual mosques, that may vary. What we did well, working in partnership with Muslim Doctors Cymru and developing links with the mosques. The mosques have been really supportive. There's been a huge acceptance for hepatitis testing. And there was great support for getting people to take up this offer of testing. And we've developed the opportunity for further screening, such as fibro scanning, and made BBV screening part of a broader offer. The really important thing, we had great admin at these events, so we had good data capture, good databasing, made a huge difference to me. It's getting the flow through the venue as well, because some people came through, they had some of the cardiovascular screening done. They didn't always make it to the BBV and the TB testing. And you need to think about flow as well, because if you've got somebody doing hands-on AF testing, you don't want to have just dry blood spotted them. So it's getting that flow in terms of infection control and trying to get people to go through the whole of what's available. Not everybody who attended made it to the BBV testing area. In the mosques, obviously, we're only targeting Muslims. We may have people of different faiths who are also from high prevalence areas, and we won't get in those people. This was the team. As you can see, there were loads of us. Thanks. Kazim, our GP, Muslim Doctors Cymru, Bethan, our public health consultant, my colleagues, and the public health team, who some of the content in this presentation I've shamelessly stolen. So thank you.
Okay, thanks very much, Gavin.
Right, so they will be the best churches to go to, because A, you'll have lots more people, and B, they'll have come from places like Nigeria and Zimbabwe.
It's interesting.
And the other point is I did some work in which is absolutely Pakistan. And then there's a strong gradient on age for HCV up there. As they've got less people sharing. I just wonder if you could come to this country, maybe young adults or born here, which might explain some of yours much lower than the 5% you see in Pakistan.
Yeah, I think we'd probably be thinking about vertical transmission for a lot of them.
It's not, yeah.
Yeah, so that would be low. You're right. It's the first generation population that we need to try and access primarily. James at the back.
Don't think we'd assess the target population. I think we were trying to bring in services where we knew there was gaps in uptake, if that makes sense.
But it was there was also a pragmatic element to it as well. There was a bit of combination.
So for those online, it was looking at cardiovascular risk because that was identified as a target area, and then also a pragmatic aspect around it, what was available for testing. Okay. Oh, sorry. Yeah. Oh, two more. Nikki.
We didn't, but that's what we'll do in the future. Yeah, might be a good thing.
Baz.
You get a breakdown of like by gender, how many men, these women did you test? Because obviously women might have had some medical interventions which may have put them at higher risk, which the men wouldn't have had, and women in general don't return risks.
I think it was about, Lisa, was it about 60-40? Oh yeah, sorry.
It's not for all events, so I think that was for the 2 events.
Yeah. I think you did a breakdown, didn't you, of by sex?
Yeah, it's there.
Yeah, but for the whole. No. Fine.
Just for the 2
Yeah.
combined events. Yeah, unfortunately, I think the first event we didn't capture that data, but
Yeah.
Okay, last question, Del.
We didn't separate them, did we? It was just done.
now it's been looking at other community settings as well. We did a much setting, but we have the ladies going upstairs, we missed a lot of them. And we looked at another sort of project, but yeah, how best to engage them in the families.
Yeah, no, they just came around the same. Everybody came around the same.
Bethan, did you have a comment or? Josie, in the interest. Oh, it's okay. Go. Yeah, good idea. I'll see what I can do around that. Okay, I promised you at the beginning that at some point during the day everything will go to shit, and so far the slides have gone okay, but I have had at least one message from someone saying that their name isn't on the room list. I'm also responsible for that, so and it's been a bit of a used car salesman job where we've been swapping names around. So if you have any issues, I'll go downstairs now, try and make myself available, try and smooth out whatever problems we're having. Hopefully most of it's okay, but I'm sure there'll be some mistakes. Okay, thanks everybody. Enjoy your tea break.
Hopefully you're not sharing a room with Brendan.
Yeah.